And for the colleagues in the room who want to start with an ablation program, I would tumours. I will talk not only about radiofrequency ablation, but also about newcomers, microwave ablation. And for the colleagues in the room who want to start with an ablation program, I would start my talk with some generalities regarding what can do the surgeon and what can do the other disciplines, because lung tumor therapy or lung tumor ablation is a very competitive field. Some generality, first of all, you have to know, and probably you all know that in this room, that the incidence of lung cancer is continually increasing, especially in women and in men, and the lung cancer remains the primary cause of cancer-related deaths in both men and women. We have, talking about primary lung cancer, of course, we have to differentiate between non-small cell lung cancer and small cell lung cancer. It's a quite different approach also for us, interventional radiologists. And if we are talking for an ablation in the case of non-small cell lung cancer, we are talking about very early stage disease with limited disease. This is not a population for ablation. Patients with small cell lung cancer have very often lymph node metastases of extensive disease. It's also a very limited population for the surgeon. Just want to say that now chemotherapy, radiation therapy are considered a palliative technique, but you have to know that there is in the last 4 or 5 years new chemotherapeutic drugs that are quite effective. It's a little bit between palliative and curative treatment. And we have also very good new technology with radiation therapy, with especially good results in the treatment of lung cancer, not really in metastatic disease, but in primary lung cancer. And when you look at the literature, of course, we have a lot of experience with metastatic disease in the lung and with treatment of non-small cell, and almost no experience with small cell lung cancer. I will show you that lung ablation is no longer only RF, and in my institution, as you know, there is microwave, there is electroporation. So in my institution, we almost let the radiofrequency ablation for microwave ablation or electroporation. And we'll show at the end of my talk some current result of larger studies with most of these studies are relating to radiofrequency ablation, just that you have some arguments if you want to discuss with the oncologists, some arguments to perform in favor of ablation. Other generalities in small cell lung cancer is about 20% of patients with primary lung disease, and we have very rare limited disease that are potentially candidates for ablation. Even if these patients are receive surgery, the overall survival rate is quite short. And you see normally the patient with small cell lung cancer that may benefit from surgery are the patient stage 1A to 2B. Normally, the other patients are not candidate for surgery and, of course, not candidate for ablation. And you see, even in a limited disease of small cell cancer, the 2 years overall survival in this patient is 20%. And it's quite similar when you compare to the result for 5 years or from 10 years. So it's not a very large improvement in the technology. For small cell lung cancer, you know there is an adeno and squamous carcinoma type. Normally, patients who are candidate for surgery as a patient up to 2B, and in even more and more institutions, also patients with a stage 3A may benefit from surgery. Also, there is some minimally invasive thoracic approach. It is one example of a minimally invasive surgical approach. Don't laugh. It's a mini thoracotomy. More important, believe, and for metastatic disease, in my opinion, not for primary lung cancer, but there is a video-assisted thoracic surgery that have shown a lot of improvement in the last years. We have different types of resection. Normally, generally, for lung cancer, we are just talking about anatomical or lobar resection or pneumonectomy. And in some cases, because, for example, of respiratory function, surgeons perform a sublobar resection. And sublobar resection is non-anatomic resection. It's something what we do when we perform ablation. So if your surgeon talks with you and say, our results are better than ablation, at least surgeons have also to compare not the lobar on the pneumonectomy with ablation, but the sublobar resection with the ablation. Last generality is that you have some information what the other discipline may do. There is clear criteria to perform a resection. Just look at these two criteria. There is major criteria against a surgery. It's expiratory volume less than 50% or a diffusion capacity less than 50%. If you have one of these major criteria or two or more of these minor criteria, theoretically, these patients are not candidates for surgery. But potentially, they are candidates for ablation. Last word regarding metastatic disease of the lung. Similarly to surgery, if you take the decision to perform ablation in metastatic disease, and in almost all cases, we are talking about colorectal disease, if you want to start an ablation, you have to ablate all metastases. If you ablate only a part, 50, 70% of metastases, the patient will have no benefit of that. It's the data from the surgery, the difference between a complete resection of all colorectal lung metastases and an incomplete resection. There is a statistically significant difference between both. So if you start with ablation of colorectal lung metastases, ablate all metastases, or make a cooperation with your surgeons, as a surgeon may resect some metastases at the surface of the lung, for example. You can ablate other metastases. Lung ablation is not only radiofrequency, just 2 or 3 slides on this topic. As I said before, we are more and more using microwave. It seems to me to be more effective, and in any case, it is faster than radiofrequency ablation. We have still some cases where we use radiofrequency ablation. We'll show you after in which cases. As there is a newcomer, I'm not sure that it will be better than microwave at the time, but we are talking more and more about electroporation also for the lung. I believe there is so few data on this topic, I will not address this topic today. These are an example of microwave antenna. As you see, it's not really, you have some experimental data here, but it's not really different from a radiofrequency antenna, radiofrequency applicator. There is 4 very good experimental studies comparing microwave and radiofrequency ablation for the lung. Just picked up one study from Madison here. All these studies have the same conclusions that microwave perform larger ablation in whole diameter, in cross-sectional area, larger surface, comparing with radiofrequency ablation for the same time, or even shorter and faster than with radiofrequency ablation. So I believe, not sure for the liver, but for the lung, I do believe that there is some advantage by using microwave. Imaging problems during and after tumour ablation. It's a radiofrequency applicator, it's a microwave applicator. There is a big advantage by performing ablation in the lung compared with the liver, is that of course, you don't need contrast medium normally, but you have a very good contrast between the applicator and the lung tissue. So that's an advantage. In all MPRs you have a good contrast for the positioning of your needle. We use very often the fluoroscopy to place the needle, not only to be faster, but in this example, with a patient with 2 metastases, large metastasis here, another smaller one at this place. We use fluoroscopy to be faster, but also if you have a metastasis like this one near a large vessel, we perform ablation without general anesthesia, so we have the participation of the patient, and we can talk with the patient and say, take a deep breath, take a small breath, so that you can perform and place your needle, avoid it, of course, to pick here this large vessel. Let the patient take a deeper breath, and so you can place, you see the other metastasis here, you can place your, in that case, it's a radiofrequency applicator. Very slowly, patient take a breath, the vessel are going on the bottom of the lesion so that you can place your needle inside the tumor. You have to control the position of your needle. It doesn't depend if you work with radiofrequency or microwave, the needle, the placement of the needle should be exact. And then you make a control. It is perfect in this example. I would strongly recommend, of course, to make MPR. It's very fast now to perform MPR with CT. And when you make this the control of the position of the needle, in this case, you see that you are at the bottom of the lesion. It is more than 1 centimeter over the needle. It's not a good position. So we have to change this position. And you change this position, and you make the second control, and you are at the top of the needle. It's also the same. It's not good. It's not the right position. So in this case, where it is difficult to have an exact positioning because the breathing of patient is different, or some cases the lesion is very small, we also use fluoroscopy to replace the needle in the center of the lesion. If you have a lesion of 2 centimeters, one position is enough with microwave. You don't have to perform overlapping ablation. So in the same way, we know now we were once at the bottom, one at the top, so we know where we have to go with the needle. And so we will place under fluoroscopy the probe, and we are exact in the center of the needle. That's the right position. In this position, you only need one ablation. In the other way, what you could have done is an ablation, one at the top, one at the bottom, and maybe one at the middle. That's the position. But it's faster with microwave to be exact in the center of a lesion of 2 centimeters to perform one session. Also, we use fluoroscopy for very small needle. I have the experience for very small lesion. I have the experience that you push your lesion sometimes. Some colorectal lung metastases are very hard, and you can push your lesion in front of your needle. So we need also fluoroscopy to place the microwave, in this case, microwave antenna, in the middle of the small lesion. For very, very small lesion, in some cases, we prefer to use radiofrequency ablation because we have expandable radiofrequency ablation. We do not have expandable microwave antenna up to now. If you have such a kind of lesion, you don't, with an expandable needle, you don't have to pick this small lesion, the small metastasis, but you can go over or behind the small metastasis, and then you expand your electrode. Like in this example, you can imagine the tumor is, you can expand your electrode, as you can see here, the small metastasis, all around the tumor, and start your ablation. How can you perform the monitoring of your ablation? Radiofrequency or microwave? The only difference by using the ground glass opacity to monitor your ablation, the only difference between microwave and radiofrequency ablation is microwave is working so fast that you have, in a lot of cases, to wait a couple of minutes after ablation to see this ground glass opacity. The ground glass opacity, and we performed a ablate and resect study a couple of years ago. The ground glass opacity corresponds to edema, hemorrhage, but in a safety, in a couple of millimeters, 6 to 8 millimeters, around inside the ground glass opacity, you have DNA strong breaks. So you have a complete coagulative necrosis. What you see here is the coagulation of the tract. We do not longer perform coagulation of all the tract, and we show you after a while. Sometimes it's difficult to differentiate the ground glass opacity from a bleeding. By using microwave ablation, there is a possibility to differentiate bleeding from coagulation necrosis. The coagulation necrosis, the density is lower than the bleeding by microwave. I didn't make this experience with radiofrequency ablation, but with microwave, the coagulation is inside the bleeding and the density is lower. The monitoring, the ground glass opacity, you use that as a monitoring. I'll show you this example. You have metastasis in this case. You have two large vessels here. You see this ground glass opacity, but you cannot recognize any ground glass opacity. Even if you wait 3, 4, or 5 minutes, what I would recommend to wait up to 5 minutes, you have no ground glass opacity here. You have the microwave antenna here. So you have to perform a second ablation by retrieve your needle, your microwave antenna, perform your second ablation, and perform the monitoring and the control in an axial, but also with MPR in a parasagittal view. So you have the ground glass opacity, you have the needle, and you have the metastasis in the middle. It's an example where we had not MPR after ablation. It was a large metastatic disease in that case. And you can see you have two metastases here. We have the ground glass opacity all around this lesion, also in this lesion, but not at that case. And a couple of months at the first follow-up examination, you have a relapse here that we fortunately could ablate, but we could have here used this monitoring here to see that we do not have ground glass opacity in that case, and the risk of recurrence is quite high. So perform MPR in 2, at least in 3 different planes to be sure that the GGO is all around the tumor. At follow-up, you have to perform your control without and with contrast medium, and normally you are supposed to have less than 15 ounce-fill units before and after ablation. If you have less than 15 ounce-fill units, it's a good indication that the ablation is complete. But you also have to scrutinize the lesion. What the normal aspect of a lesion could be the hypodensity after ablation and a very thin homogeneous re-enhancement. But if you have any nodules at the periphery, it's very suspect of a residual tumor or of a relapse. As you can see here, we have a very small nodule in that case. We have this rim at the periphery that's normal, but we have a nodule at that case. The nodule is becoming larger. So you have residual tumor tissue or a recurrence in that case. So look, rim enhancement, a very thin rim enhancement is normal. A nodule is not normal. Perform a very short follow-up. It's what you want to have. You have a ground glass opacity that is larger than the metastasis. It should be larger. Remember, you need the safety margin. And after 3 months or 6 months, it's supposed to be a very similar diameter compared with basic examination, and after you will have a scare. It's what you want. And I would recommend also another recommendation for you: perform your follow-up examination by yourself. Don't send the patient to another radiologist, because the first thing the radiologist will say is, oh, the lesion is becoming larger and larger. Perform your examination by yourself. See your patient after ablation. Just a few data on results of radiofrequency ablation. I put together 2 kind of studies relating to negative prognostic factor. And the one is the size of the lesion. It's relating to radiofrequency ablation, not to microwave. Different study, but a limitation seems to be a pulmonary lesion between 2 centimeters and 3.5 centimeters. In metastatic disease, it's a little bit larger because we have less lymphangiotic carcinomatosa in metastatic disease than in primary lung cancer. 2 to 3.5 seems to be the maximum diameter to perform radiofrequency ablation. We have one larger study with microwave ablation with a 95% complete ablation in tumor with a size of up to 5 centimeters, but we have few data up to now with a large number of patients with microwave, but it seems definitively an advantage to use microwave. In this larger study, there was no difference by performing ablation in tumor less than 3 centimeters regarding survival, and tumor between 3 and 5 centimeters. But at least when we look in detail in this paper, we have a tendency to have more recurrent disease for tumor larger than 3 centimeters. So we need more data on microwave, but in my opinion, it's definitively better than radiofrequency ablation. Another problem is the contact with large vessel, defined as vessel larger than 3 millimeters. And we have a paper with lung metastasis from Ellis Gilliams, and a paper with primary and secondary lung tumor, and the contact with blood vessels larger than 3 millimeter is definitively, for radiofrequency ablation, a negative prognostic factor. And we could show that in 2008. We could demonstrate in a Ablate and Resect study that larger vessel lead to a deformation of the shape of the coagulation. Like you can see, you can recognize this larger vessel here and here, and you see the deformation here at that place. So be aware about that. Large vessel, you have to perform more ablation or longer ablation. Just one paper, one study on this topic, large vessel and macro-M. In that case, the group from Gustave Roussy in Paris, in a tumor mimic model that could demonstrate that it could ablate 4 centimeter lesion, and there is less or no effect regarding this large vessel, not up to 3 centimeter, but also they could completely ablate lesion with a contact with vessel up to 6 millimeters. So also in that case, probably because microwave is working faster and the temperature are higher, we have less itching effect with microwave than with radiofrequency ablation. A couple of ideas for survival. If you know the survival of surgery after resection, atypical resection for colorectal lung metastasis, you see that we have a very similar 2 years overall survival here in that case in 4 larger studies with 60-70% 2 year survival after ablation of lung metastasis. When we look, we have also data regarding stage 1 non-small cell lung cancer, also with very comparative, very similar results, at least in patients that may not have surgery because of comorbidity or limited respiratory function, etc., but very similar result with, in this study, up to 47% 4-year survival. We have limited data, limited oncological data. We have much more feasibility and observational studies, but this oncological data with survival are very, very promising. I picked up 2 papers. One paper is a comparison of ablation, as I said before, not with anatomic resection. You cannot compare ablation with splenectomy. It's unfair. But if you compare ablation with sublobar resection, why did the patient have sublobar resection? Because of comorbidity or respiratory insufficiency. And if you compare sublobar resection with radiofrequency ablation in primary lung cancer, you see that there is, in this study, no difference between ablation and non-anatomic surgery. And I picked up also this other study that is very interesting because we are talking about interdisciplinarity, and combined therapy, in my opinion, is the best way to treat this patient. Also in patients with non-small cell lung cancer, this group, stage 1 and 2 non-small cell lung cancer, had either radiofrequency ablation or surgery. Also in that study, I have to say, patients who had ablation were not candidates for surgery. And stage 1, 3, and 4, they compare radiofrequency with chemotherapy alone. And what we see is, regarding stage 1 and 2, in elderly patients, stage 1 and 2, the result of radiofrequency ablation was the same than surgery. Even better if we just take the 5-year survival, 18% for RF and 0% for surgery. Also very interesting is the group with stage 3 and 4. The result of RF plus chemotherapy were statistically significantly better than chemotherapy alone. Interesting, promising. We need more study, of course, but if you want some argument to discuss with your oncologist or with your surgeon, these are 2 very good studies. Little bit different is comparison of ablation with stereotactic radiation therapy. I recommend this analysis from Stéphane Renaud. They could include 5 studies with radiofrequency ablation, also in primary lung cancer, and 10 studies with stereotactic radiation. And I put the results all the results together. We have a 5-year disease-free survival in the 10 study with stereotactic radiation, which is a little bit better than with radiofrequency ablation. The 3 years overall survival was very similar. So a very competitive field. Just a few slides about complication. We heard about complication after biopsy or drainage. It's the same complication. We have pneumothorax. Just want to advise about delayed pneumothorax. We had the chance with University of Wien to just publish some cases, case series with delayed pneumothorax. We also inform our patients that if there is any complication 3 days, 4 days, 4 days after the ablation, they have to come back. If you perform a too long ablation of the puncture tract, you dramatically increase the risk of a pneumothorax due to a bronchopleural fistula. What we do now is we perform coagulation up to 1, maximum 2 centimeters outside the tumor, and after we retract the needle. Macroeventina or RF applicator directly, only performing a longer ablation of the tract. So maybe we can summarize with this slide. I said you before, we have a very competitive field with radiation therapy, definitively in primary lung cancer. I'm sure that it's not really competitive for metastatic disease. In this just published review, they put a kind of algorithm with preference for surgery for lesion close to the pleura, preference for RFR for lesion in the middle of the lung, but with some distance to large vessel, and prefer radiation therapy for central lesion. You can take that for you, or you can perform in all these 3 cases, of course, also ablation, but it could be a kind of algorithm. Just to summarize now, I just saw this paper because it is the last paper with standard of practice, but you have also very good paper from Rose in GVIR, from Laura Crocetti in European Journal of Radiology, or for Damien Dupree in Radiology, or Thierry Debert. These 5 papers summarize what we should know if we want to start radiofrequency ablation. In primary lung cancer, we always perform a FDG PET-CT because potentially you have a curative intention and you have to see if there is extra pulmonary metastatic disease. Indication for ablation now, non-small cell lung cancer 1 and 1A and 1B for lesion smaller than 3 or 3.5 centimeters. Almost no indication in small cell lung cancer because of metastatic spread. Lung metastasis, very good indication, of course, because you can repeat ablation up to 3.5 centimeters with radiofrequency ablation. With microwave, maybe we can perform ablation of larger lesion. The only contraindication is a severe and treatable coagulopathy. And for the post-procedure assessment, we perform CT without and with contrast to detect the small nodule, to detect residual disease. Thank you very much.